So, as Dr. Jacobs said, I am also a adult reconstruction surgeon. I actually did my fellowship with Dr. Jacobs at Rush in '03, '04. So if there's anything that you have a problem with that I tell you this morning, take it up with Dr. Jacobs. It's his fault. So I'm in academic practice in New York City at Mount Sinai. And I started a company about 3 years ago called Monogram Orthopedics, and I've been encouraged at this conference to hear that a lot of what we're working on at this startup of mine are kind of common themes, and that the industry seems to be kind of buying that we're going toward customized implants and more advanced robotics. So that gives me hope that we're on the right path as far as my company goes. I got into startup orthopedics because I was a consultant at Think Surgical, which you guys may know was the offspring of RoboDoc, which was actually the first FDA-approved robot before Da Vinci, before any other robotics. RoboDoc back in the late 80s, early 90s was the first robot of any kind that was used on humans. I got involved with them after they got some financing to kind of commercialize the technology, and I was with them for about 5 years. And what I saw was the potential for robotics to do more than what we were using it for, which is to kind of do the same old surgeries with maybe a little bit more precision than we've always done. But we could actually use robots to do things like put in custom implants. And I'll talk a little bit more about that later. But so that was kind of the impetus for starting Monogram, to essentially couple custom milling with a special robot with custom implants that are 3D printed, and to kind of get that perfect fit and improve upon joint implants. So what's worked in my experience? So robotics. So as last speaker said, we're still in the first generation of robotics in orthopedics. It's kind of, the stuff that we're using now is kind of like the Commodore 64 Atari, compared to what's out there in the world of industrial robotics. The technology that's in the machines that we're currently using in orthopedics are relatively primitive compared to what you would find in like a Tesla factory, for example. They're also very expensive technology, because like Moore's law, the technology, the cost of robotics technology has continued to fall. So, where we're now paying, $1 million+ in capital expense for an orthopedic robot, really the cost of these things is coming down precipitously. So you can get a state-of-the-art cobot from one of the big industrial robotics companies for $40,000, $50,000, $60,000. So I think what you're going to see in robotics is the technology is going to improve, while the prices are going to plummet to the point where companies will essentially be able to give the hospital the robot, because they'll be using the robot to drive implant sales. So even as primitive as the current technology that we're using is, it's still really good. And it has, over the past 10 years or so since we've been using orthopedic robotics, it's gained adoption steadily, and it's not going anywhere. And part of the reason for that is that we're starting to see some data. We're actually starting to see some midterm data on partial knees that were done, in '09, 2010, that show improved survivorship over manually done Unis. So that's the kind of data that some surgeons that they're not necessarily early adopters need to see to kind of say, okay, this technology is worth it, and I'm gonna buy into it. Big thing that I'm seeing in my practice, which is kind of disheartening, is that people like sports docs in the community that were sending me partial knees and total knees and that kind of thing are taking a look at the Makos and some of the other robotic technology out there and saying, you know what, I can do this. And so now sports guys who don't really have training in knee replacement surgery, certainly don't have any training in partial knee replacement, they're doing them because this technology is so good that it takes an operation that is pretty finicky if you do it manually, and turns it into something that's much more reproducible for kind of a lower volume sports type surgeon. So another thing that I find works for me is I started doing these things called kinematic knees about 3 years ago, and it's kind of a controversial topic in joints, but I think we're starting to see some data that when you do a kinematic knee where you're kind of resurfacing the joint rather than kind of changing the angles that you put the implants in, you get patient satisfaction scores that are approaching total hip levels. You know, there's this 80% satisfaction, you know, good to excellent satisfaction rate in total knees, and I think Dr. Jacobs might agree that elusive 20% of kind of not super satisfied knee replacements is still out there. So we're still chasing that 20% of knee patients, and what I'm seeing with kinematic alignment is that we're getting a little bit closer to that 90+% good to excellent patient satisfaction rate. We're also learning that there's data coming out showing that if we put the tibia in a little bit of varus, which is how most tibia's native anatomy is, that it actually is not going to affect the survivorship of the implant. There's a big study that Mayo came out with a year or so ago looking at 20-year data, and they found that even in outliers where they put the tibia in more than 5 degrees of varus, there was no difference in revision rate. So that's added fuel to the kind of the adoption of this technique. So dual mobility hip replacements, I think, is solving a problem. You know, we're learning more, and you all probably heard about the kind of evolving knowledge base of the kind of spine pelvis connection. There's more and more research coming out on this. We're understanding it more and more all the time. But there certainly is a connection between the spine and the pelvis, and dual mobility implants can really help with solving that problem. There's one paper has been recently published showing a 7-fold increase in dislocation rate after a spine fusion in a total hip patient. Another trend that seems to be working is outpatient joints. There's been a lot of talk about ASCs and the kind of the increasing prevalence of outpatient joints, projected to be over 50% of joint replacements in the next 5 or 6 years in the United States. So this is a trend that's happening. There's a lot of cost pressure, bundled payments on the system that's kind of driving this, and the data is reasonably good. You know, there's 30% reduction in cost of an outpatient joint as opposed to an inpatient joint. The surgeons have financial incentive often with ASCs that are driving things. The outcomes are being shown to be equivalent in terms of complication rates and readmissions and that type of thing. And we're developing better and better risk stratification tools to ensure the safety of outpatient joints and to make sure that we're risk stratifying appropriately for outpatient. So as far as what hasn't worked, I just picked a couple things out of my hat. Patient-specific instruments was a fad. I don't know did you ever do that? Yeah, I mean, I tried patient-specific instruments for knees a few years ago when it was a hot topic, and what I found is it really didn't help me. It kind of slowed the surgery down. The jigs didn't fit quite right. I bailed more often than I wanted to manual instruments, and And honestly, the data has not really shown superiority of PSI as opposed to manual. So I think it's largely been abandoned by surgeons. They're still out there, but I don't think nearly as common as it used to be. Cementless tibias are definitely getting better, but in my own personal experience and some of the data with older cementless tibial implants is not great. And I think that we're seeing a trend in moving toward more cementless fixation in knees. Our knee patients are getting younger. They're roughly the same age now as our average age for hip replacement. And so the idea of not cementing is really attractive, I think, to a lot of surgeons. But cementless fixation has in the past not been super reliable. I put in hydroxyapatite, or not hydroxy, hyaluronic acid, just to illustrate something that I find in my practice, which is that patients really don't want to have joint replacement surgery, no surprise. And they will believe in just about anything that will give them hope that they can somehow avoid that surgery. And so viscose supplementation is kind of a prime example of that. The evidence is not good. It's horrible. And there have been lots and lots of good randomized controlled trial studies done, and it's placebo. And when I tell my patients the science behind it, they get pissed off at me, which is an interesting response. But because I feel like I'm trying to give them the science and tell them, no, this is not going to work. And more times than not, they think that I'm trying to talk them into surgery. So that's an interesting conundrum. So where I think the industry's going, and we've all mentioned this, 3D printing in metal continues to evolve. And so it's making customization of implants not only possible, but also practical in terms of time to delivery to the hospital and cost. So the cost is coming down for custom implants. It used to be that if you wanted a custom tri-flange hip socket, it would take weeks to make, and it was very expensive, and the images had to be manually segmented. So a lot of kind of emerging technologies are coming together to make mass customization of implants really not only possible, practical, economical, but also really potentially clinically beneficial. So if we're really careful about not just creating customized implants just for the sake of customization, but actually attacking real clinical problems, I think that there's a lot of potential here. It also makes business sense. There's obviously a huge inventory issue with the big implant companies, so moving to customization will help solve some of that. And just the modeling, the software and computing power that's available to allow images to be analyzed and processed is getting better and better, and it's kind of facilitating the move to mass customization. Again, AI deep learning is kind of along those lines, which is going to support all these new technologies. I mentioned cementless tibias before. I think we're getting there. Some of the newer implants have better data, but again, I think customization and robotics can help quite a bit optimize cementless fixation in knees, and I think that's be interesting to hear your thoughts on this. I think we're going to be using cementless knees in 10, 15, 20 years like we do cementless hips, and we're not going to be cementing knees anymore in the medium term future. Smart implants, I think we've all kind of mentioned some variant of this, but I think we'll start embedding sensors to detect things like aseptic loosening, infection, stability, wear, knee motion, etc. And then last, I think that getting past that first generation of robotics to kind of the next generation, one of the things I think will happen is we'll start getting away from fiducials. like was mentioned in the last talk. And we will have machine vision, so the robot will be able to see what's in front of it optically. We won't have to place markers. It'll just speed the whole process up, make it less painful for the surgeon, and kind of get rid of some of the fiddle factor and really make it almost universal. I think that's it. Thanks.
Thank you.